Welcome. Thanks for taking the time to join us. I'm Eileen Donnelly. I'm CEO of Ripple&Co. I'm going to be your host and your moderator today. So this session is called Rethinking Mental Health First Aid in the Workplace, because many organisations have actually invested in mental health first aiders, but aren't necessarily always that confident that the network is delivering consistent impact, or perhaps that it's not being supported as safely and sustainably as it could do. So we well know the context is hard to ignore. We know stress, depression, anxiety continue to drive significant absence in our workplaces. The Institute of Occupational Safety and Health cites 16.4 million lost working days every year, and nearly half of work-related ill health stems from stress, depression, and anxiety. So today is about getting some really practical answers. What good looks like when MHFA is treated as just one of the levers in a whole system approach. So it's integrated into how work is designed, it's led and governed, rather than it being a standalone training badge, so to speak. So we're going to cover why mental health has moved very much into the boardroom, what's driving accountability. We will also look at the UK duty of care backdrop, why this sits within existing health and safety expectations and legislation, how MHFA sits within a broad management system. So we're looking at prevention, integration, risk management, measurement, and of course, providing support. And I think we couldn't talk about mental health first aid without talking about the tension that often stalls progress when it comes to the implementation of peer support networks. And that's confidentiality doesn't necessarily mean secrecy. So how do you protect that person's privacy while still potentially providing oversight, governance, support, and of course, clear escalation when it matters? So we're going to hear from Duncan, our keynote speaker, and then we'll move on to our practitioner speakers, who each will share just a small, honest view of how it's been when they've been implementing and sustaining their mental health first aid networks. They're going to talk about what's worked, what hasn't, what maybe keeps them awake at night, and any impact that they've been able to measure from their network. But first, let's start with the big picture. Let's look at why a risk-led, evidence-based approach really, really matters. So I'm delighted that we're joined by Duncan Spencer, who is Head of Advice and Practice at IOSH. He is definitely a recognised thought leader in occupational safety and health. He's a regular conference speaker and published author, has some deep experience about applying a risk-led, evidence-driven approach across multiple sectors. He's worked with organisations to build safety management systems that are responsive, agile, flexible, and he brings real strength in health and safety governance as well as policy and strategy. So Duncan, thank you so much for joining us. I'm going to start off with a pretty broad question, and that is, why is mental health such an important topic within the wellbeing agenda? And perhaps just a nod to, where does all this attention on this particular topic originate from?
That's a really good question, and I think it's one that is actually quite important that we don't lose the context of all of this, and think about how our organisations are actually reacting to it. So the first thing to say, and the obvious thing to say, is morally we shouldn't be hurting people, whether that's psychologically or physically. We just shouldn't be doing that. But if you set that aside, actually, there are really good business conversations that are going in and around this at the moment. So where does it all stem from? Well, you can trace it back to the United Nations Social Sustainability Goals. So they've got goal number 3, which is to provide good health and well-being. And you've also got goal number 8, which is about decent work and economic growth. Okay, so a lot of people are talking about decent work at the moment. Well, that's the origin of it. It's actually in the United Nations sustainability goals. So what happens at the United Nations is of course, we've got member countries who sign up to the United Nations. They sign up to the International Labour Organization, and the International Labour Organization responded to these goals from the United Nations by saying that occupational safety and health, which of course includes well-being, includes mental health, is a fundamental right and principle at work. So that was a declaration that came out a couple of years ago. So in other words, it is now a human right in the workplace to be kept safe from harm psychologically. So what this all means from that global perspective is it places governments under pressure, because governments then, because they've signed up to the UN and to ILO and so on and so forth, they have to be able to set policy and legislation in this area. And policy and legislation being set means that businesses have to react. Because if they want to trade, and they want to trade ethically in particular, then they must make sure that they're a compliant business. So it's up to them to think about how to respond to this policy, how to respond to the legislation. And that might mean employee assessment programs. It might mean appointment of a mental health first aider network, and so on and so forth. These are possibilities, possible solutions to be able to respond to these kinds of pressures. And of course, there are some very good business arguments around this now. So businesses have to compete with their rivals, and it's compete not in the sense of only making more sales than your rival, but competing for talent. That's becoming quite an important thing for the boardroom. And of course, the generation of today are quite discerning in who they want to work for. So they want to be able to focus on applying for and working for businesses who are ethically sound, and that means having these kinds of things in place. So if we're going to attract talent, if we're going to retain that kind of talent, then we've got to make sure that we meet their expectations in the workplace. And I think all of that helps to inform society. So there's a pressure coming into the boardroom from society as well, from the customers, from the clients, and so on and so forth, because there's a heightened awareness within the population, especially in the UK, post-COVID now, because everybody now recognises that the COVID experience was not great for lots of sections of our society, including young people who have now grown up and are entering the workforce and such like. So there's quite a number of different strands there that kind of funnel down into a point where you're saying any business here, whether not just from the moral point of view, but from the good business perspective, has to take this into account.
So many things there, lots of different levers that people can pull on. And as you say, there is that moral imperative, the good business imperative, the fact that you can retain staff if you are looking after them, but interesting that you can attract them. And of course, indeed, now having worked with Oxford Research Centre, have got that well-being score. So it's going to turn people off unless actually there is evidence from within the business that people enjoy working there. So a very powerful metric. How they're measuring it in one, who knows, but fantastic that they found a way and a formula to do that. But as you say, there is pressure. There is pressure because it's coming, like anything that's new, having a background in sustainability. I saw it with carbon and waste and water, that ultimately this legislation will come. So tell us a little bit about where it already perhaps fits into the UK legislative context that we're all operating in. What do we need to consider there?
Sure. So there's been a lot of debate about this in the press and what have you, because there have been a number of people, lobbyists, who are saying, oh, we need to have separate legislation in and around this in the workplace. And there are others who say, no, actually, you don't need that because we've got sufficient to be able to cover it. So all I'm going to focus on now, rather than what's being proposed, is just where we are with it. So first of all, we've got statute law. Okay, we've obviously got the Health and Safety at Work Act 1974, and there is a provision within that which covers all risk to human activities, not just physical injury, but is mental injury as well. Section 3 of that act is the duty of Section 2, of that act is for the duty of the employer to the employee. So it is the duty of any employer to make sure that people are safe, healthy in the workplace, and go home in one piece mentally and physically at the end of the day, essentially. So that sits there, and the HSE, the Health and Safety Executive, has said for many years that includes stress, as we used to talk about, but now, of course, it's morphed into mental health systems and well-being and such like. So there is no problem with the Health and Safety Executive in saying it is covered by the statute that sits there. The problem for the HSE, in terms of you might well point a finger at them and say, but why haven't you made any prosecutions? The problem is that our brains not only work in the workplace, but they also work at home. And how much is somebody's illness actually attributable to the workplace situation, and how much is attributable to the home private life situation is terribly difficult to be able to discern in a courtroom. So as a result of that, the health and safety executive have focused down on campaigns and advice and so on and so forth, rather than going down the prosecutory route to give us things. We do have the health and safety first aid at work regulations, of course, but that first aid at work regulation is for physical injury type of things and doesn't actually cover first aid. But don't forget that there are two strands of law in this country. So you've also got the civil law duty of care. Okay, so that's where suing for negligence and all that kind of thing comes in. And there are a number of different landmark cases that people need to be aware of. I'm going to go just quickly run through a couple of them. If people want to know more about this, if you go onto the IOSH magazine website, I've written an article there that actually gives you the references and such like. So the first one is quite a landmark case. It's Walker versus Northumberland County Council in 1995. So very succinctly, Mr. Walker was a social worker. His workload got such that he couldn't cope anymore. He complained to his bosses. They didn't do anything, and he went off with work-related illness as a result of it, mental health illness as a result of it. When he came back, his employer said, okay, we'll put new regimes in place to help manage the workload and so on and so forth. And very quickly that broke down, and his workload was not only what he'd left in his desk 6 months earlier, but everything else that had arrived since then as well. So he had a second nervous breakdown. Now, the important thing here is that the ruling of this case said that the first time he went off with stress-related illness was not reasonably foreseeable, but the second time was, because there had been a date of knowledge the first time he went off for the organization that they were suffering. Now, that's really important, that date of knowledge bit, because if somebody comes to you in the workplace and says, I really can't cope, I've got too much work, and it's really affecting my health and so on and so forth. If you do nothing and they go off sick, then that was your first shot. That's your date of knowledge at that point when they've told you those things. So Walker versus Northumberland County Council was really quite important. Then we also got Sutherland versus Hatton in 2002. We haven't got the time to go into the full details. There's a massive findings from this case, massive precedent. But essentially what that case does, it sets out 16 principles for judging stress cases in a courtroom. So they're well worth looking up and getting to know if you haven't done already. But interestingly, there was a couple of interesting points that came out of that. The first one is that any employer is entitled to assume that an employee can cope with their workload unless they are told differently. Okay, if that workload is normal and everybody else in similar roles and so on and so forth, it's not abnormally above anybody else, then they can rightly assume that you can cope. Right? The employer is entitled to take what the employee tells them at face value. So if you're not coping, but you say to your employer, yeah, I'm fine, I'll be okay, then they can take that at face value. Yeah. So that's where, people start talking about, don't ask the question once, ask it twice. How are you? No, really, how are you? To try and get to the bottom of this. And then the other thing was that confidential OH advice services and referral to counselling is really important for any employer, because if they put those kinds of things in place, then it's unlikely that they'll be found in breach of their duty of care. I suppose you could add in mental health first aid provision within that as well, as being part and parcel of a system. And lastly, very, very quickly, Pratley versus Surrey County Council, 2003, that ruled that psychiatric illness is unlikely to come about in an immediate timescale, within a few days or within a week or what have you. It is something that develops over a long period of time usually. And then Young versus the Post Office in 2002 ruled that if an employer introduces a plan to safeguard an employee, they must take care to implement it effectively. All right, so you're duty bound. If not, then you're in breach of your duty towards people. So what we find here is that while the statute law is relatively weak, the civil law is actually quite strong, with very clear signposts in what you must incorporate into your system design.
I think those would be incredibly valuable to share. So I will make sure that we do that in our follow-up, because as you say, there's some incredibly challenging aspects to that case law that really we need to look at in the lens of peer support intervention. For example, is it an intervention that you could put on a par with an EAP, and therefore you are fulfilling your duty of care? But as you say, it needs to be implemented appropriately and effectively. And what's the criteria for being able to say yes, it is? I mean, it just feels from all of this, it's still emerging as it's building the plane as we're flying it, so to speak. So
what does
lots to consider still. We could have another webinar on that alone. So let me crack on with another question. So you've often talk about this 5-part framework for building an effective management system. So we're going back to that broader picture, the fact that mental health first aid is one of the levers. So can you just briefly describe that 5-part framework for us?
Yeah, I gladly. So I'll just name them first. So the first one is prevention. Okay, so that's got to be your first principle before you start with anything in occupational safety and health. Second is integration. The third is risk management. The fourth is measure interventions. And the fifth is providing support. Okay, so let's dig into them a little bit. So prevention being the first principle, it's got to be the first principle. For goodness sake, let's stop making people ill.
Yeah,
it's as simple as that, and we must do what we can to make sure that they thrive in the workplace, because that's good for business as well. You've got a thriving workforce, you've got a productive workforce, so that's really key. So many systems that I've seen, and I've seen people talk about, and maybe our colleagues will talk about this a little bit later on, but there are many organizations that kind of immediately jump to, okay, let's have an employee assistance program, let's have mental health first aiders, great, tick in the box, right, now what are we doing about this operation over here? And they kind of miss the point completely. And the point here is that's not prevention. Because if you think about it, you've got to wait until somebody is ill enough before you then say, oh, we'll make an intervention now. Well, you've just made them ill. Why didn't you intervene much earlier on and prevent them getting to the stage where they were ill? So that is the fundamental question that organizations need to be asking themselves is when and how do you make those interventions? How do you spot people? So prevention has got to be number one. So mental health first aiders and wellbeing practitioners, they've got a really important role to be able to play in a system, if that's one of the solutions. There are more than one, but it's one of the solutions that people go down. So they're important in terms of prevention, because what we found in our research was that it wasn't so much being there for the times of crisis, but it was the other things they did around promoting mental health in the workplace, helping to destigmatize the issue in employees' minds and managers' minds, and all of those kinds of extracurricular, that, if you follow what I mean by that. So that's really quite important under prevention. The complication often kicked back, but it's becoming less so these days, as people say, but I can't do anything about their private life, and if they're stressed by their private life because, I don't know, their dog keeps eating tomatoes or something, I don't know, then that's nothing to do with me or the workplace, and I can't do anything. That's kind of old hat now as an argument. Most organizations are going, yeah, but if you've got a thriving employee, you've got a thriving productivity. So let's just be sensible about this and recognize that if they've got financial worries or marital worries or health worries or whatever else it is, if we can find them help, then that's a good thing, surely, because what we don't want to be doing is losing somebody, paying sickness absence, trying to pay for temporary staff and all those other on costs that come from all of that. So it's that kind of thing of, oh, well, it's at home and it's nothing to do with us, is neither here nor there as an argument these days. People see right through that. And as I say, in prevention, that means you've got to understand how things progress, right? So you've got people in normal everyday life, they are healthy, all right, and they're able to cope with the pressures. Let's not call them stresses, let's call them pressures. The pressures of the workplace, and everything's rosy. But there might be the odd few days where things get a little bit tough, and the deadlines are getting a bit too close, or you got out of bed the wrong side in the morning, whatever it might be, and you get more into a coping mode rather than a healthy mode, and that's the kind of time where you need to be starting to pick up the signs with this individual. All right, if you're going to have an intervention process, because certainly when they get to the point where they're struggling, that's when the organization, the individual, the productivity, and so on and so forth, are all starting on a downward spiral with each other. And if you still do nothing, then they become unwell. So we've got healthy, coping, struggling, unwell. So there's plenty of opportunity for people to be able to make some kind of an intervention into that. And you have to do that if you're going to have prevention as being a core of your safety management system around this point. Integration next. So the second point being integration. I think the whole system needs to be integrated into the rest of the business. So quite often I see it as being a standalone policy in many organizations, but it's not, is it? Because there are other related policies in this area. So there's dignity at work, there's equal opportunities, there's data prevention, there's sick leave. There's all manner of different policies that sit in this space, not just well-being and mental health. So you've got to make sure that there is a really good reflection across all of those policies, that it aligns with one another. There are no tensions within it, and so on and so forth. And that's quite a job, to make sure that happens. And I would also consider in the integration bit, and there's always been the big challenge of why people just say, oh, well, I've got a stress risk assessment, so we must be okay, but they don't really do anything about it in reality, is understanding that the production within a working environment ebbs and flows. Right. So I come mainly from a retail background, and you're damn busy at Christmas, but in the early summer, not so busy, So you've got to recognize where those pressures come in. And that leads us nicely into the third one, which is the risk management side of things. You've got to understand what your local risks are. And when those risks are worse at certain times than others may be. So you've got to understand your history. That means you've got to collect your data, but you've got to understand your history. You want to know what the pressures are in your workplace. You want to know what the components are that lead to undue pressure being applied in different roles in the organization. You've even got to think about maybe what those pressures might mean to other people. So if there are huge pressures on the workforce, then what does that mean to the pressures in HR trying to deal with that? So there's all sorts of knock-on effects and what have you. Really important, recruit the right people to the right roles. So there were people that I know in retail absolutely thrived on pressure, absolutely loved, give me more. They got a real buzz out of it. But there are other people who would go, oh God, I couldn't do that job, because it would collapse me within minutes. So you've got to understand that. You've got to understand the stresses in the workplace, the pressures, and how they change from day to day, project to project, team to team even, so there's quite a complexity there in risk management that people have got to dig down deeper than just saying, what are the stresses of the workplace? Let's tick the box that we've recognized all of those. You've got to get much more deeper into this if you're going to actually make preventative actions, to go back to our first principle. Measuring interventions, number 4. So you've got to consider what are the positive benefits that you're aiming for. If you don't start off with an aim and a goal, then where are you going? So that's an important aspect of this, whether it's a financial thing, whether it's a return on investment for your investment, for your intervention. Really important that, and a mistake that's made by many occupational safety and health professionals, actually, they bang on the door of the board saying you need to do this because it's morally this, and so on and so forth, but they don't give the board any data to say, here's where we're starting. And if you intervene in this, then this is where we will end up, and we'll be able to measure that progress. Because if you can't measure it, then you can't prove that it actually had the effect you had. which is one of the main things that came out of the mental health first aider research that we did earlier on, that most organizations, there were dozens of organizations that were looked at in this research, and none of them pretty much had anything around, okay, we've appointed mental health first aiders, so what effect has that had in the workplace? How we benefited from that intervention? And it's all kind of supposition and qualitative rather than having any really robust evidence behind it. So that's really important. What do you measure? What are your reporting mechanisms? How do you report? How do you analyze your reports? How do you learn from those reports to improve the system? All of those things sit in there. And then largely providing support is as almost like a last resort more than anything else. There's so much more that you've got to do first. Is the employee assistance programs that you might want to put in place, and the transparency you might put in place around the system, the appointment of mental health first aiders into your system to have certain roles and certain definitions within it, and so on. So that providing support is important, but it's not the be all and end all. And it's where most people start and finish, but actually there's so much more that you need to think about within your management system.
Yeah, a brilliant walk through that management system. And as you were talking through it, I was thinking, yes, how much people tend to start with the last, and it's about support rather than prevention, which in any health system, you want it to be more around prevention than cure. But also I was reflecting on how that 5-part system could actually work specifically for mental health first aid as well. The duty of care, the looking after those who are looking after others, if we were to apply that framework to them as a population, would actually be very interesting, because again, do we to what extent do most businesses not do all of that comprehensively? And I guess that's the point you made earlier around the fact that it's got to be an effective mental health first aid network. And that really, for me, is all the way from prevention all the way through to support. And for that reason, I do want to sort of press you on this specifically. The appointment of mental health first aiders, what should organizations ideally be considering?
It's a good question, and actually it's a question that we asked researchers in 2017, and we published research in 2018 as a result of it. If you go onto the iosh.com website, you can actually download this research for free as part of our charitable notice. If you put into the search engine mentor, MENTOR, it will come up with the appropriate site. We call it our mentor project. And it worked. We worked with Mental Health First Aid England and Nottingham University to be able to carry out this research, because we felt very much at the time that there was this mushrooming of activity around training people in mental health first aid, and it was raising all sorts of questions. And so this is a really important study to start to try and hone down what those questions are that organizations need to go away and think about. So, first question really is to think about how do you appoint your first aiders? How do you know that they're the right person to appoint? And the right person is a difficult thing to talk about, because people are motivated for all sorts of different reasons to actually volunteer to be a mental health first aider. So you've got to be clear that they are the right reasons. You don't want the busybodies, do you? But also you don't want people who are not going to be able to cope with the tales of woe from others. So they've got to have something about them. And that then raises a second question, which is, well, how do you refuse people when they put themselves forward as a mental health first aider, and say, actually, you're unsuitable? So, many organizations say, well, you can come to the training and there's an assessment on the training, but you might not be appointed as at the end result, so at least they're meeting them with halfway house. But there's a cost to that, of course. So you've got to bear that in mind. So people might be enthusiastic, but you've got to have the ability as an organization to say, I'm sorry, but no, it's not for you. You've got the wrong role. You're the wrong type of personality. It's not going to be helpful for you to do this. You've also got to think, when you appoint these people, that they have got time or the wherewithal to be absent from their role for a while, because when people get themselves into crisis, there's no planned time for that. They get into crisis. So you've got to be able to respond to them very, very quickly and move away from your role. And you might be gone for a while. People can be, quite poorly, and if we're going to exercise our duty of care, then we need to make sure that they get the support they need, and move to people who are better qualified to be able to do that. There are other questions as well, like first aiders, sort of physical injury first aiders in the workplace are often paid a bonus in the workplace. So do you pay a bonus? And is that why people are therefore, putting themselves forward? You've got to think about other things like if you've got too many mental health first aiders, do they see too few cases? In which case, how do they keep their skills up to date? Most first aiders will tell you that they will see, a first aid case once in a blue moon. So that's why we have refresher training. But there's no refresher training for mental health first aiders, unless you want to put one in place, of course, but that would be a good idea. So there's also questions around, well, how do you continually professionally develop, people who are in those particular roles? Accompanied with that are other things like, they might hear some harrowing stories and what have you. So how do you counsel them? So what kind of support network do you need to put together for your mental health first aiders so that they can support one another in what they're doing? Because otherwise they're going to be quite isolated around this. And importantly, they're going to be an important source of information for you. So how do they bring that information back into the organization so you can learn from these cases? Whether it is work related or non-work related, you're still trying to respond for the good of the employee. So you've got to be constantly thinking about how you can improve and enhance and so on as you move forward. And dare I say, how do you evaluate mental health first aid effectiveness? Because they're going to be good ones and they're going to be bad ones. So, how do you recognize, how well these people are doing as they move forward? I suppose there's something else to consider here as well, which is about how in what context mental health first aiders are appointed in the workplace. Sometimes they can be appointed as advocates for the employee. I've heard that many times from many different organizations, some of which are quite large and household names. And they state that whatever is said to a mental health first aider is confidential and not to be disclosed any further. They're advocates for that individual. Yeah, but I'm not so sure about that. When you think about it for a second, and I heard a very learned lawyer talking about this on a stage once, and I wish I'd written his name down, but I'd forgotten. But anyway, I'll give you the gist of what he was saying. It's not been tested in court yet, but what he was saying was this: if you think about it, as an organization, you have decided to appoint mental health first aiders as part of your system, right? So there is a bona fide role there that you see as being part of the fabric of how you do business, right? You've then been through a selection process and a training process and an appointment process to put that person in place. You've even made it possible for them to leave their normal duties to go and deal with those kinds of situations, right? So how can you turn around and say that that person has not been appointed in some way as an officer of the organization in that broadest sense of the term officer, right? That's tricky, because if you say mental health first aiders are advocates for the employee and they will never tell the organization, everything is confidential in that room, it might be construed in certain circumstances. They say, but you were appointed by the organization, therefore you were acting on behalf of the organization. You were told that this person was ill, but you never told anybody else. And now this person now has grounds to be able to sue because nothing was put in place to be able to help them. Yeah. So there are some trickiness around that. Now, I'm not a lawyer. That's as I understand it, in terms of in broad terms, and it refers back to that date of knowledge thing that I talked earlier about in Walker versus Northumberland County Council. So if an employee discloses to a mental health first aider that they are ill because it's work related in the workplace, or it's privately, but work is making it worse, or whatever it might be, you can't then say that the organization doesn't know, because it was said to somebody who was appointed to listen to that kind of stuff. So that's to be tested in court. So I don't know of any cases, and I keep an eye on that, but I don't know of any cases yet that has tested that. But it's an interesting legal conundrum, I think.
It's a tricky one as well, just to jump in there. I mean,
Yeah, please
it's
do.
a very tricky one, because I've sort of had lots of conversations on this absolute point. And, you know, the beauty of peer support outside of a workplace is that sense of safety, that
Yeah.
I can talk to this person and know I can be authentically who I am and disclose whatever.
Mm.
However, and absolutely to your point, that does change when we look at a workplace. And the lawyer you're referencing, I know exactly who you mean. I can't remember his name either. So that's a quest for me for the follow-up. I think this is where we are building the plane as we're going up. You know,
Yes.
what should be the descriptor of this person, and how might we protect the person's privacy and confidentiality, yet still have some kind of awareness of regularity of conversation, or precipitating insight into the fact that there is a potential work-related injury. You know, what can we do to track and get a sense of the data of what we need to know to continue our duty of care appropriately, both to the person who's being supported, but also the person who is supporting. And this was sort of back to my point around supporting those who are doing the caring. So I think this is going to be probably one of the trickiest, but possibly, I hope, going to be one of the challenges that is resolved as soon as, so that we continue to implement effectively interventions. Yeah.
Yeah, and I think as a final point, what you said at the beginning in your introduction is so true. You know, that confidentiality does not mean secrecy. You know, we have to find ways where we can keep private information about individuals private, but we can still operate with that information in a way where the company can learn from it.
Yeah.
Line managers can be informed about it, and appropriate rehabilitation processes put in place to help that individual, you know, back to full productivity and health. You know,
Yeah.
and that's the real nub of this, I think, in terms of that management system that I was talking about earlier on. You've got to have some kind of reporting mechanism. You know, you've got to have a way of being able to draw line management into this. Otherwise, you are not exercising your full duty of care. You know, you couldn't possibly be, because people would be unaware of it, and you might be making the problem worse as a result of that.
Yeah.
So, you know, it's kind of rock and a hard place stuff in many ways. I think part of this people get, and I'm talking from my own experience here, so there's the health warning, right? In working with occupational health nurses in the John Lewis Partnership, mainly when I used to work there. The important thing is that you can keep certain information private, all right, but you've got to recognize where medical in confidence actually stops. And we've got to recognize as well that actually a mental health first aider has no medical status whatsoever. So adhering to some kind of medical confidentiality, well, you know, you can have a non-disclosure agreement between people and what have you, but don't start saying, oh, you can't do it because of medical science, because that's not actually true.
No,
all right.
no.
And this is what I meant earlier on when I was talking about your system needing to be transparent to your employees, so that they know if they do come forward for help, it will be treated sensitively. But in order for us to be able to help you, there are certain things that have to happen, and certain people have to be involved in that. And these are the people, including your line manager, who would have to be informed about this. And then there another level, you need to take some kind of an overview of these individual cases and say, where's the commonalities, where's the similarities, what are we going to learn from this as an organization in the way that we operate and the way that we want to do things, if we're going to move forward. And we're going to create that decent work in a fulfilling workplace and such like, which most boards now are focused on delivering.
And if that data, as you say, is collected in the right way, protecting personal details and the the minutiae of the conversations, then actually the wealth of insight, and therefore the more preventative approach we might be able to take, particularly for organizations, as we're about to hear, where there are hundreds of mental health first aiders. Imagine the hundreds and hundreds of conversations and therefore data points that we might be able to draw on to then take a more proactive stance on tackling mental health and poor well-being. So amazing. Thank you so much, Duncan. What I'm really keen to do now is bring our sort of practitioners in, those who are working in the businesses. So guys, do come back on camera. We've got with us Bryony Littler from United Utilities, who's worked in mental health now for 9 years. So she brings a really strong applied psychology lens to workplace wellbeing. She's got qualifications spanning counselling, psychotherapy, all the way to a master's in applied psychology. We've got Claire Burgess from Unipart Group. She leads the workplace wellbeing programme there, oversees a network of around 200 mental health first aiders, but also 50 wellbeing champions as well. So she brings over 20 years HR experience into practical delivery. And Dave Hope from HSBC, who has 37 years in banking and passionate about both physical and mental health alongside his corporate career. He's the group exercise instructor and an MHFA instructor trainer. And he's created himself this MHFA role and the rollout program within HSBC, helping it grow to a network of some size, which we will hear about, with quite a sizable target for the end of this year as well. So we're going to hear from each in turn. Brian, if I could come to you, and then Claire, and then Dave.
Yes, thanks, Eileen. Hi, everyone. So my name's Bryony Littler. I work for United Utilities as Health and Wellbeing Business Partner. And a big part of my role is looking after our mental health first aid network alongside everything else. And I kind of always describe my role as preventative instead of reactive. So we've got occupational health and an EAP and reactive support that is there potentially for when either people are in crisis or they notice a change within themselves and they decide to access support. But a big chunk of my job is getting people to use it sooner rather than later. And I'll come on to that in a second. But I guess in starting our approach, we had a mix of people who had done, it was mental health supporter training, I think, when I joined. So I've been here about 5 years, but that was one day. And it was key in kind of people understanding what mental health was, understanding signs and symptoms and what they saw in people and what they might recognise at work. And we had that group of people alongside wellbeing champions who again supported more of the physical and mental health messages that were coming out via calendars and business communications. But it was at that point we thought everything's a bit too diluted and brought in mental health first aid to the business. So we've got now internal trainers. And in that setup, I think kind of a lot of what you guys have just been talking about, a lot of what you've described is we built it into our strategy. So in terms of prevention and providing the right support or getting people to use the help sooner rather than later, it was really important that we got the right people to do this training. So we've got around 1 in 10 of our colleagues trained at the moment. So around 400 on the way to 500. And that's the 2-day training. So it was a step up to what they'd previously done either as wellbeing champions or supporters. And in that process, I guess kind of without making it form, we tried to put a bit of structure around it. So we recruited people. So we had a pledge. And that very much outlined, I guess, kind of what the training was, what the expectation of people who were acting as mental health first aiders would be. And that was for both the colleague and their manager to talk about. So their manager understanding they need some flexibility in their job because they might get a phone call or they might see someone in distress. It's not that they're going to take 2 hours out a week or an hour a month. It could be nothing 1 month and then 5 hours the next month, we don't know. So that's what the pledge was brought in for, so that people could actively confirm it was for them, see what the I guess the challenges will be for them as well, because it's not necessarily always going to be nice things that people are coming to them for support for. So that was part of getting people into the training. As I said, we've got internal trainers, so we train people up doing the 2-day course in person or online to allow for people that are not based around the Warrington office. So there's the flexible ability to do the training. And then following on from that, they complete the training. They are part of a network, so they get regular communications in terms of like emails, newsletters. Recently started putting out little video shorts and trying to keep with it, like we call them mental health minutes. So once a month there'll be a topic or a focus and it pulls on what they've learned in the training. So say this month is all, or April, sorry, we're moving into stress awareness month. So it'll say, remember the stress bucket, you use that in your training. How are you talking about that within your teams? How are you spotting signs and symptoms and actively asking twice, how are you when you've spotted something? And then alongside that, we offer we call it like a quarterly session. And it's not supervision, but I think that is more of a space where I'm really passionate that we need to look after the people who are looking after everyone else. And I think these mental health first aiders, they don't get paid like physical first aiders at the moment. They are all doing it kind of either through personal experience, their own interest, they're giving up their time and supporting other people. So we give them 2 hours once a quarter or so, and that's where we'll get our senior leader sponsor in to talk about key messages. They've done the training, so they are also part of that community. It's an opportunity where our mental health first aiders can come together, support each other. Listen, we always say, share it non-identifiably, but if you've had a complex or a challenge that you've supported somebody with, or you've got experience, because again, if there's some members of that community who are more active than others, they can share best practice. They can, if they've been engaging their team around a topic and somebody's more confident than someone else, they can find kind of like a buddy in that. So that's worked really well. And it encourages them to seek support from each other outside of those sessions as well. As I've mentioned, we've got a leadership sponsor as well. So Tom is our bioresources director, and he kindly took on, he wanted to do the 2 days training. I think he's got kind of his own personal reasons, as well as understanding how important it is for us as a business to be focusing on this topic. So he hosts regular communication sessions, so he sends out emails and all of that sort of stuff. But it's not without its challenges. I think one of the biggest things that I find, and I'm really looking like this is my role, part of my role within the business. So it's not kind of an addition, but keeping the community energized sometimes can be a big challenge, and finding new and exciting ways to talk about mental health, because it can be quite heavy. And I think sometimes a lot of the communications is negative. It's, kind of spoken about in a not the nicest way. And I think we want to look after everybody else. Yes, we want to spot signs and symptoms so that we're not waiting until somebody has gone off with stress to then look at a risk assessment, but it doesn't necessarily mean it always has to be reactive. We can talk about it in a positive and preventative light. So that was kind of, I guess, one thing that I'll take, and I'll steal anything with pride if anyone can share it. Sorry?
I was saying, absolutely, steal away the idea. Yeah, that's great, Brian. Thank you so much. Claire, can I hand over to you?
Yeah, Claire Burgess. So I head up our health and wellbeing program within Unipart. Been in the role kind of 5 years. So pre this role, it was kind of, I suppose, a bit of a side hustle within HR. So wellbeing was kind of that add-on, that extra hat. And I don't want to really dwell on the pandemic because that brings up different emotions for different people. But I look at it as it provided me the opportunity to follow something that I'm really passionate about. So it enabled me to kind of move from that HR kind of generalist area into something a bit more specific, and kind of, I think when purpose meets passion, it can be quite powerful. And one of the first objectives I was given by the business, who had already kind of risk assessed and spoken to the lawyers in terms of, so you made an interesting point, Duncan, in terms of, once you have this role, you're empowering people to almost represent the business. What does that mean? So we did quite a bit of risk assessing in terms of, what does this mean? And one of my first objectives was crack on, set up a mental health first aid program, get people recruited. And I think the benefits I had was, I can get quite excited about these things, and I just kind of run off at 100 miles an hour. But my experience, because I spent a couple of years volunteering with Shout, was I was kind of already thinking, how do we safeguard? How do we make sure we get the right people? Having experienced a lot of those conversations, we've got to make sure that we don't cause harm to the people who want to support others. So how do we recruit? How do we train? What do? We don't have internal instructors. We had to find a supplier, an appropriate supplier. We had to kind of trial and make sure that worked for us. And we've been working with them for 5 years now. The feedback is incredible. So if you find someone who kind of mirrors your same values, you can build quite a powerful kind of partnership. And the first few cohorts was kind of like create that model line. What does good look like? Test it, safely before you kind of start to upscale. And in those first few cohorts, we used individuals that would help us then create the rest of the program. So it was deliberate and strategic. We've had the senior HR team go through it. I had some of our internal trainers, some of our senior operations individuals, people who headed up teams, people within HR. So all these kind of different areas of the business that would kind of bring a different view to how we moved forward. And I think that was really powerful in terms of how we've been able to kind of upscale. And then when we started rolling out the cohorts, we used the data. I'm a big fan of data. So where have we got absence, where people are openly saying and reporting that it's due to mental health? Because for me, that felt like the door was open. Actually, people were safe. People felt safe talking about it. So we moved in that direction. And we started to kind of, I suppose, trying to demonstrate and measure the impacts. And what we did see, and I don't have the numbers on me right now, but we did see a reduction in that absence figures. So we were really keen on how do we measure, how do we track conversations. So we've logged conversations from day one. We've been really hot on making sure we maintain that confidentiality. But if it's something that's worrying us, we have a path to take that forward. So part of my role is to look at those commonalities, look at that data. Is there a particular situation or a particular issue that keeps coming up in a site or in a particular part of the business? And that's where the data becomes quite powerful in terms of moving that forward and trying to identify risk and kind of supporting individuals that may be struggling. But part of that is also kind of looking beyond the data and making sure that we're looking at the humans as well. So we may have lost 4,000 hours, but what does that mean in terms of people? Because that could be 4,000 people. It could be 40 people. It could be 5 people. What's the severity? And then what do we need to do to get behind it? So we now have we're working on par with physical health. We too don't offer a payment for mental health first aiders. That was debated quite a bit. And I received quite a bit of pushback around that. But for me and for a number of the mental health first aiders, we felt quite strongly that if we were seen to be receiving a payment, actually, would that stop people coming to talk to us? Would that then increase the perception that you're only doing this because you're getting paid and actually you don't really care? And for us, it's all about creating that safe space so people can come and talk to us and making sure that peer network kind of works. Things that have gone really well, there is an appetite for it. I have a waiting list on an ongoing basis for people who want to do the training, which is incredible, but it's also exhausting trying to keep up. It's like the snowball just keeps coming. So yeah, as the person who kind of heads the program, yeah, that can be tiring. Managing expectations is also one that can be a challenge. Well, why can't you do a course? Well, I've got to get 16 and actually then I've got to do this. And it's the expectations and understanding. But we do have some really strong senior leadership sponsorship. We're now as a wellbeing, I say we, I also manage the occupational health team, and we outsource to a number of kind of other disciplines, including specific mental health, occupational health providers. We have senior leadership. One of the things we have in terms of that senior piece is we are now firmly embedded within our health and safety system. So we have accreditations to 45001. We have just had our wellbeing management system and all the things we've created, including the mental health first aiders. It was really important to make sure the governance was firmly around that program. And so we now have aligned ourselves to 45003, so we can make sure it's auditable. We've got baseline, we can see where we're making improvements. We can see, importantly, where we can kind of improve. And similar to Bryony, we have quarterly reflective sessions. We now have kind of a role between the mental health first aiders and myself, which feels like, but it grew organically. So we now have mental health first aid leads on sites, and they hold monthly sessions where they can practice their skills. They'll talk through fictional kind of scenarios. What would I do? Because not everyone will have a conversation regularly. and we do monitor how many conversations are being held by any one person. I can see from a supporter perspective through our provider who's doing the most in terms of conversations. Actually, does that pose a hazard for that individual? What can we do to help kind of spread the load a little bit more? So we're constantly kind of in that two-way kind of comms piece to make sure that we can improve. There's so much more I could go into, but I'm really conscious of time, so I'm going to.
That's great. That's great.
I'm going to leave it there,
Thank you very much. Thank you, Claire. And Dave, finally, tell us what's happening at HSBC, because there's some big stuff going on there.
Yeah, so slightly different for me in that the role that I do is side of desk sort of thing. So all voluntary, and all our mental health first aiders are voluntary as well. It's not specific roles. If we go back to about 2022, we had about 100 mental health first aiders. We had no central system to record it. Any training was all sort of done locally. So I'm part of the employee resource group. I'm the co-chair for the mental health strand as well. And we identified this as a problem. We brought it all centrally in. That meant we set up a central register. So we had a list of all our mental health first aiders that we had across the organisation. And then from that, we were able to move into sort of our next stage, which involved us trying to secure a central budget for the training. And we brought the training internally. And the advantage of doing it that way meant that we had none of the objections in terms of, I haven't got a local budget to spend. It was fine. We can do this. We'll provide you exactly the same course, but there's no cost to your business for that. So that proved really popular in terms of assessing the people that wanted to then come forward. We used to have a sort of selection process that went through, and we'd ask people why they wanted to be mental health first aiders. But actually what we found, one of our biggest sort of challenges is, because it's side of desk or additional stuff, is the administration that needs to go around it. So we took the decision at the start of this year, actually, that we would stop asking people why, because what we found, because it was a voluntary process, everybody was coming into it because of a lived experience and wanting to give something back. And we didn't really have anybody coming, again, they're not paid for it. We didn't have people just coming because they've been forced to go on it, or you've got to go on that course, or it'll look good for your career. Everybody was interested. What we have as a safety net, though, is our internal instructor trainers will identify, will talk about why people are doing it during the course. And we have blocked people from taking that final stage if we didn't feel it was good for those individuals at that time, or there was another reason to do that. We've now got up to 700 mental health first aiders within the organisation. I've got an internal aspiration to get to about 1,500. But similar to the other speakers, we have a process in place now to support our first aiders as well. So we have weekly meetings, and they're voluntary, but they cover well-being. We talk confidentially around cases, so we don't identify who it is that we've been talking to, but again, that's for peer support to try and help if somebody's got a situation or something they don't know how to tackle. Because nobody can be an expert in absolutely everything, it's there to support that. And then we'll also have one session a month where we're focusing on a development area. So for example, next week we're talking about male eating disorders. So just trying to build on stuff all the time. But we've also introduced refresher training as well. That was a point that was raised earlier. So every 3 years, the certification expires, and we offer that refresher training in-house as well. If people want to carry on, we have a very low dropout rate. Which is good to see. The challenges that we have, we've got sort of the natural turnover of staff, so we have to maintain our internal logs and trying to keep up on top of that. So most of our challenges really are around sort of the admin side of things, which is why we try and streamline it as much as possible, because there's no central HR department to deal with that. I think in terms of our successes, we're really sort of talking, the numbers of people that we've got. We've seen a reduction in sickness levels within key sort of areas within the business as a result of that. The anecdotal feedback that we get has been very, very good. We are currently looking at statistics. We're looking at the BSI around the suicide that's being introduced recently, and we're looking at our stats that we've got on that and seeing how we can develop that and analyse information from that. I think there's a lot I could really go into, but the biggest success really is, I think, is from that anecdotal evidence. So we have stopped members of staff and customers from taking their own life as a result of introducing our mental health first aiders. And we also use our skills now in that wider community as well. And that's probably the thing that's been the greatest success, I would say, as well as just hitting those numbers. Amazing.
Thank you, Dave. I mean, it's very clear from all of those case studies that they are networks that are being supported. And I think that's, as back to that 5-part management system, one of the key elements of this particular intervention is supporting those who are supporting others. So some really interesting examples there. So thank you so much for sharing those. We are at the hour. We haven't managed to fit questions in, but I think we've really had a rich conversation, and hopefully everyone has learned an awful lot. So thank you so much, all of you, for being with us today and sharing your stories, and Duncan especially for being in conversation. Thank you very, very much.